Welcome, and I am delighted that you could join us for our session on re-engineering the study feasibility assessment process. So with that, let's go ahead and officially get started. Just a little bit about my background. I have been in the trenches of clinical research operations for 30 plus years now. I stopped counting at 30. And I've been involved in rescuing and rejuvenating literally hundreds of clinical trials. And so a lot of my perspective comes from things that go wrong in the feasibility assessment process and ultimately end up with the symptoms of failed study enrollment, performance, site compliance issues, and other types of site performance issues. So my passion and interest is really enhancing protocol optimization and site performance up front, but most of my work is in the rescue situation. So hopefully I can bring to bear a number of theoretical and practical considerations, some job aids, some tools, things for you to think about in your organizations. We have a number of learning objectives. I'm not going to read each of these in detail. They were outlined in our course information, but essentially I'll be covering all things feasibility, and feasibility means lots of different things to different people. So I'll touch on different interpretations, practical applications, some of the different types of job aids, and so forth that can really enhance ultimately enrollment and site performance. So with that, let's get started. So as I mentioned, when we think about the word feasibility, it conjures up different things in different people's minds. And I think it's actually unfortunate that in our industry, the term has gotten equated with feasibility questionnaires. And people will often say, well, I do feasibilities, using it sort of as a plural, meaning they send questionnaires out to sites to try to ascertain if a site is suitable to do a study. But I think if we take a step back and ask the question, what are we really trying to do when we're determining whether a protocol is feasible? And if we look at the dictionary definitions, is it doable? Is it achievable? Is it viable? Is it executable? And so we need to think a little more broadly about what question we're asking in relation to feasibility. Is the protocol doable anywhere in the world? Are we asking, is the study feasible in certain regions or countries based on disease prevalence? Are we asking, is it feasible to do at an individual site, and are they well suited for our study? So I'll break this down a bit because I think it really helps us to clarify what our expectations are based on the different stages that we're at. So I'll be curious. I'll do a little polling question, Michael and Michelle, with you folks. When you think of feasibility, what is the real objective? Is it that you're trying to get information to avoid an amendment? If that's the case, go ahead and use the raised hand symbol. Is it to optimize country allocation and site selection? If you think that's the objective, the green check. Predict or accelerate enrollment, the red X. Achieve deviation-free, on-time, on-budget results, use the go backwards button. All of the above, the go forwards button, or if you think feasibility objectives are really something else, use the smiley face button for me. It looks like, Michelle, you're in the camp of the all of the above. See what, and Michael's saying. Yeah, and there's no one right answer, but I think this is why it's important to have the conversation internally about what we're trying to accomplish at what different stage, because our objectives could actually change bit, and that brings clarity and focus to the kind of information we're going to ask from whom at what point in time, depending on what our objectives are. Just briefly, this data may be familiar to all of you, so I'm not going to spend a whole lot of time on this, but this comes from the Tufts Center for the Study of Drug Development that does a lot of benchmarking data, and over the years they've been monitoring the changing landscape with protocol complexity. And essentially, in this period of time, they were looking from 2000 to 2003 and then 2004 to 2007, sort of how protocols have become more complex in terms of number of procedures, the unique types of procedures, this investigative site work burden that increased 54% in this period of time. And I think they periodically update this. I'm not sure if I have the latest facts and figures, but the message is that protocols are getting increasingly more complex. And if anyone's interested in some of the articles where they actually sort of calculated work burden, it's interesting sort of earned value units and things that they did to try to calculate the impact that these increasingly complex protocols have for the sites.